First of all, I want to thank the organizing committee for this meeting. Our talk today about do we need to do anterior transthorathic release before posterior transvertical screw correction for adolescent idiopathic scoliosis, because it was used for many years, this technique, and Professor was here in our department begin when we take the MD thesis on scoliosis with severe curves. We used to do anterior release at first. With advancement, we began to advance our techniques. Adolescent idiopathic scoliosis is a three-dimensional deformity of the curve of the spinal, the vertebral column, not affecting only the coronal plan, but also there is rotation of the vertebrae and the distortion of the sagittal panels that affects adolescent less than 18 years old post-menarche. Shortly, the biomechanics of the spine stability is the stability of the spine is controlled on passive factors like the ligaments and disc space and the surrounding tendons around the vertebrae, and the active form in the form of the muscle surrounding the vertebral column, in addition to the neural feedback system that control in harmony with the active and passive sustains the biomechanics of the spine. Any distortion of these subsystems causes deformity in the form of kyphosis or scoliosis, because the vertebrae have 6 degrees of freedom, so it can rotate or displaced. So the deformity can occur in the sagittal plane in the form of kyphosis, or the coronal plane in the form of scoliosis, or axial plane in the form of rotation, and actually this happened in the adolescent idiopathic scoliosis. The curve location can be thoracic from T2 to T11, or thoracolumbar from T12 to L1, the apex of the vertebrae, or the lumbar spine may be the only side of the scoliotic curve. The incidence of adolescent idiopathic scoliosis consists of more than 80% of scoliosis all types is the adolescent type. It's more common in children. 2-3% children less than 16 years old suffer from scoliosis. Female predominate with a ratio 6 out of 10 to 1 to male. There are other types of idiopathic scoliosis like juvenile less than 4 years and infantile less than 4 years, and juvenile from 4 to 10 years old till puberty, because the adolescent type appear actually at puberty. There are some factors that lead us to suggest that this curve is going to be progressive, and we have to manage it early as possible. When we face a female patient, a girl, there is high risk that this curve will progress at premenarchal stage. If the bones are premature with razor sign 0, the double curves are more liable to be progressive curves. Thoracic curves have a risk to be more progressive than lumbar curves, and also when we discover a patient with severe curves, we have to manage as early as possible, not to wait with his braces or physiotherapy. He won't get any benefit from these maneuvers. To diagnose scoliosis, there are some signs: unleveled shoulder, the appearance of the scapula on the concave side, increased space between the body and the elbow while standing in neutral posture, and rib hump or lumbar prominence appearance on more the prominence on leaning forward, like this patient. When we read a scoliotic firm shortly, we have to identify the apical vertebrae of the structural curve, which is the most displaced from the central sacral vertical line, and the most rotated vertebrae. And also we have to identify the upper end vertebrae of the curve and the lower end vertebrae, which are the most tilted but less rotated, and we can, when we plan our fixation, we stop at the upper end vertebrae and lower end of the structural curves. Also we identify the flexibility of the curve, and for example in this curve we have double curve, a thoracic curve with the apex at T10 and another curve at lumbar curve at L3. When we do pending film, which is a must in any investigation, we have to know which are structural curves and the compensatory or non-structural curve. When pending film we do, here the curve still, the thoracic curve appear when bending to the right. On the other hand, when we do pending to the left, The second lumbar curve completely aligned, which means this is not a structural curve, it's a secondary non-structural curve. So when we plan a fixation, we don't have to do instrumentation on the lumbar vertebrae. And for also the flexibility could help us to assess during operation if you are going to have aggressive surgery and do osteotomies, or we have simple curves that we can manage simply with a derotation technique or cantilever technique. The cup angle is the angle drawn from the upper end vertebrae, upper end plate, and lower end vertebrae. We draw two perpendicular lines. The angle intersecting is the cup angle, which is our main measurement. We assess the sagittal balance, which is mandatory. We use the blunt line. Link's classification is the most commonly used classification in adolescent thoracic scoliosis, and he actually classifies the curves, analyze it in more detail according to structural and non-structural curves and the sagittal balance and the deviation. When we do a treatment algorithm for the scoliosis, we assess according to the cup angle of the structural curve. For example, if the curve is less than 25 degrees and the skeletal maturity is mature, we have to follow up this patient as needed. But if this patient is not mature, we have to follow up him with plain X-rays every 6 months until full skeletal maturity. If the patient is from 25 to 45 degrees, and he is skeletally mature, we make the follow-up every 5 years to assess the progression of the curve, because the progression of the curve after maturity is very, very minimal. And he actually won't need surgery in most cases. But if the patient is not mature yet, we try bracing and follow up every 4 to 6 months. And the bracing may gain benefit, but I have my own experience that if the curve is going to progress, it will progress even if you try with its bracing. If the patient is more than 40 degrees, we consider surgical intervention. And now there are some papers saying that we can wait till 50 degrees. But actually, the surgical correction indication is not only on the curve side. There are many other factors that we have to put in consideration. Most of the patients coming for correction are for cosmetic reasons. More than 90% of the patients. The increasing curve, if it's small curve, we have to manage. Severe deformity, if there are more than 40 or 50 degrees. If there is pain in painful curvatures, we have to do further investigations like MRI and more investigation. If there may be more than the scoliosis problem that we have to assess, analyze very well. Our goal is to arrest the progression, achieve maximum permanent correction, find cosmetic appearance, which is the main aim for the patient and his relatives, and maximize post-operative function with minimal complication. There are many maneuvers used to correct scoliosis. There are non-fusion techniques, but we are actually using here the fusion techniques. There are posterior instrumentation only, anterior instrumentation and release, anterior instrumentation only, and the combined approach using the anterior followed by after 2 weeks the posterior correction. This is here compares the anterior lead followed by posterior correction and direct posterior correction in severe curves with scoliosis. We have two groups, group A 9 patients and group B 13 patients. The group A we use anterior release first. The group B number are not equal because this paper done when we began to use the posterior approach more than the anterior release. We take history taking, complete physical and neurological examination, sterilize the patient, complete radiological evaluation from CT, multi-slide CT and MRI, and for sure the X-ray, pulmonary function test. And for sure the anesthesiologist must assess the patient very well. It is the keystone in our surgeries, anesthesiology. And to let the patient get more blood bags, this is a bloody operation actually. Even if you try to be very meticulous, the patient loses blood a lot. Our also operative plans that we assess analyze with some software the angles of the patient and the kyphotic and the thoracic kyphosis lumbar lordosis, and the plumb line assess the displacement because it helps us to reshape the rods to get maximum benefit of the sagittal balance. It's very important to, during correction, not the coronal plan, the sagittal plan must be corrected as well during surgery. Here we use, in the anterior release, we identify the apical vertebrae, and we take 2 ribs above to focus and make incision on this rib above the level of vertebrae. And we open in layers and excise the rib and open the mediastinal pleura and expose the apical vertebrae. For sure, we retract the lung and make good dissection and open the mediastinal. Open the mediastinal pleura and to preserve the segmental vessels that are crossing on the vertebrae. We actually we did release from 3 to 5 levels, the apical disc space, and 1 to 2 levels above and below, complete disc removal, and the anterior longitudinal ligament. We preserve the posterior longitudinal ligament to avoid cord injury, and we pack the disc space with gel foam and the bone chips from the excised vertebrae. After 2 weeks of this surgery, we do the posterior approach, where we use posterior transpedicular screws. After good dissection and good hemostasis, at first we use not all screws technique. We use, because the financial of the patients, we use only apical anchor and upper and lower anchor, and use at the apex screws, and we support our construct with sublaminar wires. Because we didn't use at this time the osteotomy technique. After the advancement of spinal surgeries, we began to use Smith-Peterson or Ponti's technique, where we used to completely release the vertebrae, the posterior element from the spine, the lamina, and the facet and the pars, complete release of this as the apical vertebrae and the 2 to 3 levels above and below. For example, here are some pictures. We go laterally till we completely release the posterior element right and left from each side and expose the roots. This gives us more flexibility and good correction at the apex. Another technique we use is the derotation technique, where we shape the core, the rod, according to the shape of the curve. And we make derotation 90 degrees, so the concave became the kyphotic, and the convex became like this one. Here we do this one where rotation becomes the kyphosis, and the other one, the lumbar one, became the lordosis. This derotation technique is very simple and gives good result with small curves, but actually with rigid curves we must do more manipulation and more release before we do it. The third technique we use is a cross-rod technique with cantilever beam fixation, that we make anchor above and anchor below, fix at one side and fix the rod on the other side, and slowly we go with cantilever and pressure technique, do correction step by step. Here's one of our cases that we use not all screw technique and sublaminar wires after surgery. During surgery, we use in severe rigid curves neurosurgical monitoring, especially motor evoked potential, and waking up test if the patient can afford. Thoracoplasty, if there is, after complete correction, there is still rib hump, we do thoracoplasty, and actually this became a little bit used, except it curves more than 100 decup angle. Debridement of the necrotic tissue is a must. Complete irrigation during surgery. Grafting using either the rib removed or the bone removed during surgery, and closure in layers. The suction relieved until less than 50 milliliters, no fluids for first day, pulmonary toilet, intravenous antibiotics, immobilization, immobilized gradually, and hospital actually about 5 to 7 days. Assessment of the mass fusion every 6 months to avoid radiation exposure to the kids too much. For sure, the examination of the patient neurologically post-operative and the plain X-ray. Our results, for sure, the female were dominating the study with a ratio 81% for the females. The most common age were 15 years old. The cup angle for the two groups, we insisted that both of them are high grade, so the mean was 80 in the group A and 78 in group B, with the mean 46 here and 43 here. Thoracoplasty was used in 18 patients. The graft from spinal scoliosis and exercise rib. Fusion level range from 9 to 15 and follow-up from 1 to 5 years. The height gain about 2 to 5 centimeters. Alignment was the good correction of the shoulder for about 90% of the patient group A and 88 from group B. For the cup angle pre-operative, to make it short, the child balance were the same in both groups. The cup angle correction after the surgery was from 80-28 and 87-13 in both groups. Okay, خلاص معلش. Okay, conclusion that then cup angle with flexibility of both cases were insignificant in both cases. Here is one of our cases with this scoliotic curve that we do anterior release followed by the posterior correction with complete correction of the hump and the coronal balance. This is another female patient with a high curve, 85 degrees. We use also anterior release followed by, we can see here the mark of the anterior release, and this is cosmetic surgery, so we have to minimize our incisions in the patients. Another case with a right dorsal lumbar that we use or not all screw and will have good correction post-operative. This is the last case with severe rigid curves that we use all screw technique and only Pontius osteotomy and posterior release, and we have good alignment post-operative in this patient. Even the ribs here became expanded post-operative. Our conclusion is scoliosis surgery is mainly indicated for cosmetic and psychological reasons in progressive curves. The less rigid the curves and it's a more correction and maintenance correction could be achieved. No established or international access standards for surgical procedure or for all levels of major curve need to be included in the instrumented arthrodesis. Posterior only approach with the use of pedicle screw construct has the advantage of providing the same correction of anterior posterior spinal fusion even with rigid and large curves with less morbidity. A posterior all screw technique ensures significant cyclograph and clinical correction in the 3 planes, especially restoration and maintenance of both coronal and sagittal alignment. The wide use of osteotomies, especially the posterior osteotomy like SPO and vertebral column section, is dealing with rigid curve, provide better results, and thank you very much.